and welcome to Let's Talk CNAs, a show for CNAs by CNAs. I'm your host, Wendell, and this is my lovely co-host, Angel.
Hello, and we are here in Phoenix, Arizona.
Yay, yay!
And we are here to talk about speech therapy.
That's right, Angel. A lot of people don't know much about speech therapy, but today we're going to learn a lot with our guest, Leslie.
All right. Well, that's awesome.
So, Angel, are you ready to start the show?
I sure am.
Well, let's get crunk. Let's have a conversation.
Let's talk CNAs. Let's talk CNAs. Let's talk CNAs. Okay. Let's have a conversation.
Thank you for being on the show, Leslie.
You're welcome.
If you can tell us a little something about yourself.
Okay. My name is Leslie Colvin, and I am a speech-language pathologist, and I've been practicing mostly in skilled nursing facilities for about 24 years.
All right. 24 years. That's a long time.
Yes, it is.
So you said it in a way that most people don't say it. You said speech.
Speech-language pathologist, that is the technical name. It's abbreviated SLP, so that's usually what you'll see. People also say speech therapist, which is the same exact thing.
Okay. That's awesome, because we have a big question that 25 CNAs wanted us to ask you. Okay? So that question is, why is it called speech therapy?
Okay, well, I don't know about the historical accuracy of my answer, but started out with speech therapy. So it was really working mostly with children and, helping them to speak.
Okay.
But it has grown a lot, the field, speech language. So we also do a lot of language. People who've had strokes and can't talk very well. So it's not just the speech part, but it's coming up with the words, so the language part. But of course, the field has grown even more to include medical speech pathology. So most of what a lot of us do in skilled nursing facilities is swallowing. So that's not even in our title, but it is most of what we do. Probably over 90% of what we do in long-term care would be swallowing disorders. So feeding, swallowing, also hearing, cognition when people are confused from any kind of neurological disease, dementia. So it's really a huge field, and the title speech language pathology or speech therapy really does not explain it at all. So I am sorry for the confusion, but that is how it is.
All right, thank you, Leslie. That was a great answer. So I hope that was a good answer for you guys.
And you know what? You kind of answered the question that I'm going to ask you, but I'm going to ask you anyway. What is the purpose or job of a speech therapist in long-term care setting?
Okay, so when we get a patient who has just come into the building, they might come from any type of setting, hospital, home, we don't know. And we try and look at them and see, have they had a change in their confusion levels, change in their ability to eat or swallow, are they losing a lot of weight, have they had a pneumonia, what kinds of things can we help them with? Are they able to communicate their needs? Are they able to understand what the staff and the CNAs are saying to them? Can they follow directions so they can do their ADLs? So those are all things. Can they hear? Can they hear what we're saying to them, or can they just not understand it? So those are all things that we look at in skilled nursing facility.
Oh, great
Awesome.
answer.
Okay.
So can I ask you, what do the hearing part have to do with it?
Well, obviously, if you can't hear, you might not be able to understand what people are saying. And then the cases where they can't hear, we would probably refer them to an audiologist, and they would have their hearing tested, possibly get hearing aids, and just make sure that they're not having any medical issue, which is just a hearing problem. But if you can't hear or you can't understand what's being said to you because you've had a stroke or something like that, obviously it's a lot harder for staff to care for you because they ask you something and you don't do it. What's going on? Why are you not able to follow the directions if the CNA says, let's go into the bathroom or let's go to lunch or whatever it is? It's important to know what they can understand so that we can communicate and care for them.
Okay. That makes sense. I really understand that. Okay, so what signs and symptoms should a CNA look for that may be indicative of the needing of a speech therapist?
Any changes in communication, understanding or speaking, more confusion, and the thing I see the most is weight loss, not eating well, any changes in their swallowing or eating. And I know that CNAs get to know their people really well, and they see the changes before anyone else does. I get most of my referrals from CNAs, even though I always say, please tell your nurse, because that's what you're supposed to do. But mostly they come directly to me and tell me, like, this person's doing something different. Can you come look at them? And I'll go down there and see what's going on.
Right.
But so, you know, there's a lot of different ways that the CNA who knows that person can see a change and ask the speech therapist to come look at them. And if it's not a speech-related thing, I will, you know, help them out figuring out, is it a dietary, is it PT? Sometimes there's a lot of confusion with the adaptive equipment, and they think that's speech therapy. That's really OT. But, you know, they're in my office, so I just say, oh, no, that's OT, and I just give the information to them, you know, so that's fine.
Okay.
And then I also noticed that a lot of like the therapists and the doctors are going more and more to the CNAs because they're hands-on and they know exactly what's going on. So they go more to the CNA.
Absolutely.
You know, so
I've always, well, first of all, CNAs have the hardest job in the facility, so thank you so much for everything you do. But yeah, the CNAs know more about the patients often than the nurses do. Not that we don't love the nurses too,
we love
but we
them.
love them, love the nurses, but you're the one who's in the room with them, taking care of them most of the time, and you're in the dining room with them when they're eating, and you're in it, you know, taking them to and from activities, so you see what they're able to do all the time. So, absolutely.
That's awesome.
So, what are some useful techniques a CNA can use when feeding residents with special requirements?
Okay, so the first thing I want to say is please make sure they're awake.
Yes,
Please make sure they're awake. Because so often, some people are never fully awake and we still feed them. But if it's somebody who is normally awake, please wait until they're woken up to feed them, because that is a huge risk. We do not want to be putting food into people's mouths when they're sleeping.
Correct.
So that is one issue. Make sure they're awake. Make sure they understand what's happening.
Right.
Like, what are we doing? Are we eating? Okay, great. Because some of them don't open their eyes. They may not know what we're about to do.
Exactly.
Communicate with them. Tell them what they're going to be eating, and or what they're drinking. Those are all things that, you know, we'd want to know. If we couldn't see our plate, I want to know what it is. Do we want a surprise? You know, don't mix all their food together, please.
Don't do
would
that.
you want to eat that? No,
Don't
if
do it.
it's the noodles and the meat, okay, that sounds good. But do you want the noodles and the meat and the applesauce? Okay, possibly not. Like, think about how you would want to eat that food and do it that way. Communicate with them, and you'll know your people don't like certain things. Some hate vegetables, some hate meat, whatever. And, you know, if they don't want it, don't eat it.
Exactly.
And if they stop eating, it may be that they're full, but, you know, maybe if they don't like it, maybe there's something else that we can offer them. If you know they love peanut butter and jelly, give them peanut butter and jelly or whatever it is.
That's awesome. That's awesome.
And I know some of the people will be like, I don't like the way that was, but they have to eat that. It's like, well, you know, would you like applesauce better?
Right.
You're used to
And
something
there's
like
some
that.
people, especially with puree, and we all understand that puree does not always look that appetizing. And, you know, I hate ever having to put somebody on a puree diet, but unfortunately sometimes it's required. Sometimes some of the things that we can do, and you can try in your facility with either the kitchen or the therapist, is putting it into smaller bowls. So sometimes when they get like 3 different little bowls, it doesn't look as unappetizing as when it's all spread out on one dish.
Right.
And then we have some who might just want to eat yogurt and mashed potatoes, and, you know, maybe not the healthiest variety, but if that's what they want to eat, things that are more standard puree foods that aren't made into a puree.
Exactly.
You know, puddings, all that kind of stuff. You know, that's okay too. We have to do what's best for the patient.
That's awesome. Yeah, neighbors always first. Our residents always first.
And then with the drinking consistency, you know, some people don't really like it. Kind of goes down weird.
Right, the thickener.
Yeah.
Yes. Well, have been some advances in the thickeners that we use, so that is improving a little bit. Some facilities do have pre-thickened liquids, which are better because they don't clump, they don't get that grittiness, so that is usually tolerated a little better. If they're served cold, they are so much more appetizing than if they're room temperature. And then some people like certain flavors more than others, so that's always an important thing to consider. And most therapists do want to keep them on as thin a liquid as possible because nobody wants to be drinking something super thick unless it's a milkshake or something like that.
I always wonder, does it actually quench your thirst?
It's really hard to say. I've tasted a lot of the thickened liquids, but I'm not drinking it long term forever, so I can't really say. And a lot of our patients, residents, neighbors, however you refer to them, is they aren't always able to communicate that to us.
Right.
I mean, the people I talk to who are able to communicate and have had it long term, they say it's not the end of the world.
Yeah.
It's not the best thing, but if it's going to keep them from getting aspiration pneumonia and ending up in the hospital, it might be worth it.
That's putting the residents first.
Right.
So I just want to go back just a little bit, Leslie. You said sometimes you refer that particular resident or neighbor to OT. Can you just real quick just tell everyone what OT is?
OT is occupational therapy, and most facilities will have speech therapy, occupational therapy, and physical therapy. Generally, like super easy way for us to explain it is like PT is from the waist down because they do all the walking. OT is kind of the trunk area, arms, getting dressed, toileting, and then speech is kind of from here up. That's kind of how that's the super quick, easy explanation.
Yes.
All right, that was
It's a little more complicated than that, but
But
It makes sense though.
Yeah,
It makes sense, especially if you've been in Longterm for a while.
Yeah.
You understand that,
Yeah.
so it makes sense. All right. So, Leslie, how do you evaluate a resident for swallowing disorder, and what are the various meal and liquid consistency?
Okay, so how we evaluate patients when we see them in the facilities, it's called bedside evaluation, even though they may not actually be in bed, because we are looking at how alert they are, how they're able to communicate, if they can follow directions, because if we come up with certain strategies to help them swallow, but they can't follow them or remember them, then they're not particularly helpful to that person. And then depending on what level they're at, like if they're already on Pur'ee and thickened liquids, we're going to start with that. We're not just going to give them regular food when we know they're already on Pur'ee. And so every patient is a little bit different. The different diets that we have is regular, which would be what anyone could eat, mechanical soft, which is either ground or chopped, meats, small pieces of pasta, vegetables, not raw vegetables, soft, bite-sized things, so it doesn't take as much effort to chew. And then there's puree, which is the food is blenderized with liquids to make them smooth. It's more like you would see as a baby food type of consistency. And then liquids, we have thin liquids, which is drinking everything you could want, and what we call nectar, honey, and thick. And pudding thick. Nectar is a little bit thicker than thin. Honey is more of a honey consistency, and then pudding thick, which is almost basically the same as a puree diet. So it's very thick. You can't. Pudding thick is like spoon. You can't drink it out of a cup. You have to have a spoon. Rarely does anyone go on pudding thick because really it's almost not a fluid anymore. And there are some things that are super tricky, like people think, oh, ice cream, you eat it with a spoon, that's thick, right? Well, when ice cream melts, it's milk, so it's thin. And Jell-O, as soon as it melts in your mouth, that's thin. Snow cones might be a bite ice, it melts, it's thin. So all these things are actually thin, although they could kind of trick you into thinking that they're thicker. So those are the different diets. There might be some variation depending on where you work, but they're pretty standardized.
Okay. So, in long-term care, it's custom that you say if a person is mechanical, to make sure that you're cutting even a sandwich, even though that meat on that bread is chopped up, but you should still cut the bread. Would you say that is a true statement, or?
Well, usually the meat that's going to be on a sandwich should be like thin, like deli meat. So it's not like a big, thick slab of meat like you might make at home.
Right.
So it should be pretty thin. So even if they get a big piece of it, it's not going to be a huge chunk of meat. So it's thin, and a lot of times they'll use ground up meat. So tuna, which is already chopped up really small, or if they're making ham salad, it's chopped up pretty small. Some people can handle like a whole half a sandwich, no problem. Some people really need to cut more into quarters. It really just depends on that patient, you know, kind of what they. I mean, if they're going to try and shove an entire half a sandwich in their mouth, then they probably shouldn't have half of a sandwich. That should probably be cut up. But it really depends on the person.
Okay, that's a good answer.
Yeah.
Awesome.
So what information from the CNA is useful to assist you in your evaluation?
Well, I always love hearing from the CNAs how the person's eating, like how much they're eating, their meal percentages, and what, you know, are they staying awake for the whole meal? And are they chewing? Are they using their dentures if they have them or not? Because teeth are a huge issue. If you can't chew up your food, you're high risk for choking and also probably not eating that well. And, you know, are they refusing to eat? Or are they just, what's going on with them? That's what I want to know. And a lot of times they'll say, oh, well, the person's eating 100%. I'm like, great. But then I go in and see them and 50% of the food's on the floor.
Yeah,
So I'm like, well, that's not actually 100%, that's 50%. And so then we were like, okay, let's give them another 50%, like give them a sandwich or something like that, or let's get them a second meal, because if they're dropping all their food on the floor or it's falling out of their mouth, they're not actually getting that 100% nutrition. But the CNAs always have awesome information for me about what's going on with that person, because I'm not there all the time. And a lot of our people, as you know, are different at night than they are during the day. So I need to know, how are they doing at 9 o'clock at night or midnight if they're up all night long? Because I am not there. I read the notes, but I'm not there to experience it. So.
And I'm sure different meals each resident probably perform different.
Yeah, and we have some who don't ever eat breakfast. They hate breakfast. They don't want to get up for breakfast, so they never do well at breakfast. If you do make them get up. And lunch might be a great meal for them, and then dinner's horrible. And we also serve, in most buildings, 3 full meals. And a lot of these people do not eat 3 full meals, and they haven't for years. Even before coming to us, they would have soup and half a sandwich and a little bowl of oatmeal. Like to them, that is a full meal. So we're asking them to eat a lot more than they would.
Right. Awesome. That's great, Leslie. It was great to have you on the show.
Oh, yes.
You gave us some great insight into speech.
Okay, speech language pathology.
There you go. I wasn't going to butcher that word. Yeah, great show. Thank you for being on the show.
You're welcome.
Do you have any last words?
Well, I asked one of my Facebook groups, speech pathologists, what is the number one thing that you would say to CNAs if you could? And they all said, oral care, oral care, oral care.
All right.
Oral care.
High five. Yeah, I definitely agree with that. All right, well, that's it here. Thank you for being on the show.
You're welcome.
Thank you for watching the show, and we'll see you next time on Let's Talk CNAs, where knowledge is empowerment. Well, I would say today's show was a great show, Angel. What would you say?
I thought it was absolutely awesome.
This was an awesome show. And I want to thank Leslie for being on the show. She really enlightened us on different aspects of speech therapy.
Thank you so much, Leslie.
Yeah, thank you very much.
And we would also like for everybody to join us on Instagram, YouTube, Facebook, and Twitter.
That's right. So thank you for watching the show. And again, we'll see you next time on
Let's Talk CNAs, where knowledge is empowerment.
Woo-hoo!
Let's talk CNAs. Let's talk CNAs. Let's talk CNAs. Okay. Let's have a conversation.